Thank you, Mort. I may be the voice on TV, but a lot of the voice has been provided by people in this room, people like John Rumberger and Paula Raji and Leslie Shaw, who stepped out but will be back. So this is a unique opportunity to present data, most of which has been published by the people who are in this room. And we're going to start off by talking about imaging coronary calcium. This is basically the information that John Rumberger presented, or that Mort used for John Rumberger's presentation in slightly different form, which looked at the issue of MIs in young people and how many of them, had they been seen by their physician the day before, and an LDL had been available and a Framingham risk score had been calculated, how many of them would have been judged to be of sufficient risk to be started on a statin. And that basically is what we're trying to do with prevention, is to identify those people who are at risk. And if you look at those who would have been sent out the door without any drug therapy, it's 75% of the population, which is an astounding number. In the high-risk category, those who have a Framingham risk score greater than 20% with 2 or more risk factors, fully half would have been said, fine, you're in no trouble, leave, and then would have come back with an MI. In the next highest risk category, the 10 to 20% 10-year risk, 44% would have been sent out the door. In low-risk category, less than 10% Framingham risk, 94% would have been dismissed. And in the very lowest risk category, those in whom you don't even bother to calculate a Framingham risk score because on the basis of conventional risk factors, their risk is too low, more than 80% would have been sent out the door. Now, if these 2 lowest risk categories comprise just a fraction, a small fraction, of those who developed an MI, it really wouldn't be that big a deal. But in fact, the very lowest risk category comprised 50%, and the next lowest risk category 20%. So 70% of these patients were in the very lowest risk categories. So I think we can conclude very safely that using the Framingham risk score is abysmal in calculating the risk. This is data that you all know. Every year, more than 1 million people have an MI. For 500,000, it's the first symptom. For 150,000 of those, it's unfortunately the last symptom. 2/3 of women and half of men with sudden cardiac death had no prior known CAD. And as Erling and PK pointed out years ago, 2/3 of them occur in the setting of a non-stenotic lesion, and more than 1/3 have a normal total cholesterol. So coronary calcium has been around for a long time now. It's probably 15 years, and all of you are very familiar with it. And what I'm going to do over the course of the next 10 minutes is to rehash the data, because in order to make a point, in order to gain acceptance, it has to be data-driven. We cannot use intuition. Normal scan, moderate calcification, severe calcification. If you look at EBT in comparison with arteriography and IVUS, this is an arteriogram with some disease in the left main, LAD, some diffuse disease in the circ. You look at the intravascular ultrasound and you find that densely calcified plaque on the IVUS corresponds to densely calcified plaque on the EBT, and less densely calcified plaque corresponds to less densely calcified plaque on the coronary scan. So the sine qua non is that where you have calcium, you have plaque, and John Rumberger very elegantly demonstrated, a century ago, excuse me, John, that if you plot the plaque area against the calcium area, it's a remarkable linear relationship. Our values of 0.9 are almost unheard of outside of the laboratory, and even then they're fairly rare. Now, one of the arguments that we hear is that, well, it doesn't really matter. As we age, everybody develops coronary calcium, and we know that if you live into your 9th decade, yes, be you a man or a woman, you will have plaque. But at earlier decades in life, there is a lesser incidence of detectable coronary calcium. And we have large databases of over 40,000 people, which tell us that it's not just the amount of plaque that you have, but how much plaque you have for your age, the calcium percentile. For instance, a 70-year-old man with a calcium score of 69, which is not very high, is in the 25th percentile for his age, which is a lower risk category. However, that same amount of plaque in a 40-year-old puts that person in the 90th percentile. Premature atherosclerosis, and as Paolo has very elegantly demonstrated, clearly at higher risk. And let's talk about the data. Well, this is Paolo's paper, which was the first one to talk about it. Over 632 people, just like you or I, hopefully asymptomatic, in their 50s, some of us older, some of us younger. And patients who had a 0 calcium score in this retrospective study had a 0.1% annual event rate, with increasing calcium scores having increasing event rates up to 4.8% for scores over 400. Any coronary calcium had at least a 2% per year event rate, which is a secondary prevention equivalent. If you look at percentiles and you compare the upper quartile of all the coronary risk factors combined, the NCP risk factors, compared to the lowest quartile, 7-fold increase. For the upper 25% of coronary calcium scores, a 22-fold increase in risk. So the risk given to higher calcium scores is exponentially greater in terms of the odds ratios for coronary calcium than for any other parameter that we have yet measured. If you look at the percentiles and you break them up by deciles, once you cross the 50th percentile for your age, you exceed the 2% per year event rate. So anybody who has a more than average amount of coronary calcium for his age is at the same risk of having a heart attack as somebody who's had an MI, a CHD risk equivalent. Some people would argue about using 50th percentile or 75th percentile, but the point is very clear. The higher your percentile, the higher your risk. Second study, 1,172 asymptomatic subjects from Yadon Arad. As your coronary calcium score increases, here greater than 600, a 20-fold increase in risk, and these are the odds ratios for the conventional risk factors. For diabetes, hypertension, high cholesterol, and age, and we'll come back to diabetes a little bit later, we can see that the coronary calcium score dwarfs conventional risk factors. Nathan Wang, in almost 1,000 patients again, after you adjust for age, gender, hypertension, cholesterol, smoking, and diabetes, a calcium score greater than 270 still gave you a relative risk of 8. Now again, these were all retrospective studies still. George Kondos, in more than 5,000 patients with a 3-year follow-up, found that in patients who had events, fully 95% had detectable coronary calcium, and I'm going to come back to this. And the relative risks for any coronary calcium, this is not above a certain score, it's the simple presence of coronary calcium, was 11-fold for men, only 2-fold for diabetes, 1.4 for smoking. In women, it was not quite so powerful. It was probably underpowered in women. And then finally, we come to the St. Francis Heart Study. Not finally, but in terms of large numbers of patients. This data has unfortunately not achieved peer review publication other than in abstract form. We hope that it will be published quite soon. But this really answered the criticisms that have been raised. Well, your data has been self-referred. Your data was retrospective. None of that was true in this case. Prospective, population-based primary prevention study of 5,500 men and women, 0 self-referral. Average follow-up of 4.3 years, 122 with the events as outlined here. And what did we find? We found that if you had 0 coronary calcium, your annual event rate was 0.12% per year. I guess you were wrong, Paolo. Instead of 0.11%, it's 0.12%. The message is it didn't matter if it was a retrospective study or a prospective study. If you have a 0 coronary calcium score, that is your risk, and it's a very, very low risk. Corresponding increasing scores had a greater risk, and if you look at the relative risk of a high score greater than 600, 32-fold more than a 0 coronary calcium score. And again, there is no other marker, there is no other parameter that offers this power. Fascinatingly, if you do conventional Framingham risk scoring on them, and you look at the intermediate, so-called intermediate 10 to 20% Framingham 10-year risk, fully 2/3 of them by actual outcomes, were either in the high-risk category here, in red, or in the low-risk category, in orange. So Framingham risk score was wrong 2/3 of the time and was correctly predicted by tertiles of the coronary calcium score. In the high-risk category, which everybody assumes, well, we know enough about them, they have high risk by Framingham, we assume they're high risk. Well, in fact, 45% of these were either intermediate or low risk. And in the low-risk category, a significantly lower percentage were moved to higher risk, but still, it was not that insignificant. And if you follow the epidemiologist's holy grail, if you look at the area under the ROC curve, it was significantly greater for the calcium score than for the Framingham score. In a wonderful piece of work, Leslie Shaw with Paolo and Tracy Callister looked at all-cause mortality through the National Death Registry in patients without known CAD, looked at over 10,000 patients, average follow-up of over 5 years, and found that as your coronary calcium score increased, less than 10, 10 to 100, 101 to 400, up to 1,000, and greater than 1,000, your survival very clearly, in a very stepwise fashion, decreased. And again, if you look at the area under the ROC curves, it was significantly greater for coronary calcium than for Framingham. Let's talk about diabetes for a minute. Diabetes, in addition to the factors that Erling mentioned, is considered a CHD risk equivalent. Is this really so? Well, Paolo and Dan Berman and Leslie looked at this, and they found that if you compare patients with no diabetes to patients with diabetes, there is the same stepwise increase in risk with higher scores, and at any given level, it's worse for diabetics than for non-diabetics, and diabetics are 10 years older in terms of their vascular age than non-diabetics. But if you look at patients who have a 0 calcium score, it doesn't really matter if they have diabetes or they don't have diabetes. The outcome is basically the same. So once again, diabetes, is it really a CHD risk equivalent? I think not. Are diabetics at higher risk? Yes. But we have the ability to do risk stratification even in the high-risk population of diabetics. What about patients who have a lot of coronary calcium, scores greater than 1,000? And in past years, you'd hear, well, these patients are better off. They're protected because the plaque is calcified. Now, this, of course, doesn't make sense from what we know now. This is 100 asymptomatic patients with a calcium score greater than 1,000 compared to matched patients who are symptomatic with severely abnormal nuclear stress tests. Their annual event rate was 25%, not 2% or 5%, 25% per year, compared to 70% for symptomatic patients with severely abnormal nuclear scan. So it is not whether your disease is obstructive, it's what your plaque burden is that's important. And if you compare it to CRP, a study by Park et al. Published in Circulation, when you go from a low to a high CRP at any level of calcium, whether it's low, medium, or high, you increase the relative risk by about 50% to 100%. When you go from a low to a high calcium score at any level of CRP, you increase your risk by 400%, 500%. What about retrospectively now? We've talked about prospectively. If you have a 0 calcium score, you're at very low risk. If you have a high calcium score, you're at high risk. What if we look at people who have events? How many of them would have escaped detection by looking for coronary calcium? In this study, in a relatively older population, asymptomatic patients, before their first event, average age 57, 95% of these had detectable coronary calcium. Okay, those patients are a little bit older. What about younger patients in whom you might have thought that exclusively soft plaque would have been responsible for the event? They might not have had the same frequency of detectable coronary calcium. So this looked at 100 patients, mean age 41. And they found, in fact, that 95% of these patients, these younger patients, had detectable coronary calcium. More than 85% were above the 50th percentile, and more than 60% were above the 90th percentile for your age. So it doesn't matter if you're young or old, you're only going to miss 5% of the events. So coronary calcium identifies the pool of patients from which 95% of the acute MIs or unstable angina will emerge. EBT or coronary calcium does not identify the vulnerable plaque, and as John Rumberger has, quoting John Rumberger on this, it does identify the vulnerable patient, and we're still after the vulnerable patient. The vulnerable myocardium, I think, is a bit premature in terms of delivering health care on a widespread basis. So who should have coronary calcium scores? And actually, the Society of Atherosclerosis Imaging, in our first meeting, came up with guidelines which, in fact, are more or less what we're proposing as part of SHAPE. Some slight variation. We said that males greater than 35 or females greater than 45 without known heart disease who have risk factors, So sort of loosely defining an intermediate risk category, but delay 10 years if no risk factors. So what we're saying is, using point number 2 here, males over 45, females over 55 should be screened, and that is what we're proposing with SHAPE. We will talk in the future, and we can talk tonight about certain risk groups in which we will use this parameter, males greater than 35, females greater than 45, diabetics, patients with a family history for premature coronary disease. But this is the basic paradigm that we proposed 4 years ago. Acting on this, actually, Gorbachev and Reagan signed the EBT treaty, which mandated EBT by those same guidelines for American and Russian citizens. It unfortunately was not implemented then, and which leaves us somewhat in the quandary that we're in now. The Prevention 5 update, published in 2001, EBT recommended to improve prediction in intermediate risk patients, 6 to 20% Framingham 10-year risk, comprising 40% of the adults in America. The final report of NCP-3 said, measurement of coronary calcium is an option for advanced risk assessment in appropriately selected persons. In persons with multiple risk factors, i.e. intermediate risk patients, high coronary calcium scores greater than the 75th percentile denotes advanced atherosclerosis and provides a rationale for intensified LDL lowering therapy. Particularly promising, interestingly, he says, for older people. So this has been in print and recommended by NCEP back in 2002. The AHA guidelines for cardiovascular disease prevention in women, published this year in circulation. Intermediate risk here, one of the markers of which, subclinical cardiovascular disease, coronary calcification. So we now have the recent new implications for the NCP guidelines, which I think most people accept as the new NCP guidelines published this year, in which for the higher risk patients, the optimal LDL goal is less than 70, and in general for the higher and the lower risk categories, the bar has been lowered for initiation of therapy and for the goals. And it's interesting, there is no intermediate risk category anymore, as has been pointed out before. It's just high, moderate, and lower. So what we've done, and this will hopefully be in print in another venue and will be discussed at later meetings, is we've come up with an integration of coronary calcium scores with those NCP guidelines, the newer guidelines. Why are we doing this? Well, we're doing this because the NCP guidelines are still regarded as the Bible. They are, to discard them totally would be counterproductive, and there is some value to them. So, and without going into this in great detail, patients who have a coronary calcium score of 0, and this is in patients who are in the lower, moderate, and moderately high-risk groups. We're not talking about the high-risk group per se. 0 calcium score puts you in a Framingham lower risk equivalent. Score between 1 to 10 and greater than the 75th percentile puts you in the moderate risk. 11 to 100 and less than the 75th percentile, moderately high risk. 101 to 400 or greater than the 75th percentile, high risk, and greater than 400 or greater than 100 and the 90th percentile, which I left out of this slide here, in the highest risk category, with therapies according to the NCP guidelines. Because we want to be able to take the NCP guidelines, factor in the coronary calcium score, and use the same therapeutic recommendations, but with the NCP category modified by your coronary calcium score. Hippocrates commented on this many years ago. He was a Surgeon General of Greece, as you all know, and here he said in Greek, translating it, "O Schmoth, just do the calcium score." And Bill Clinton's big test, this was in Time magazine, quoting Dr. Sanjay Gupta, when he felt chest pains, he finally got an angiogram. Should you get one too? Well, I think the answer is no. But he says here, that's why there's been so much attention given lately to a non-invasive test called EBCT, using x-rays, etc., a good measure of how much plaque has accumulated there in a study published in the Journal of the American College of Cardiology. This is from Dan Berman, an absolutely wonderful landmark study. More than half of 1,119 patients who passed their stress tests had high calcium scores greater than 100, in subsequent EBCTs, suggesting significant hardening of the arteries. It's not the end of the story. If you get a high calcium count, you will still need an angiogram. No, of course, that's missing the point. We're not saying that. But EBCTs are spotting a lot of hidden heart disease, although some insurance companies are reluctant to pay. Its use is growing rapidly, and it may eventually become part of the standard heart workup. I'd like to end this talk with a tribute to David King, who, for those of us who knew him, are absolutely convinced that he's up there looking down on this session and saying, wow, finally, it's about time. Thank you.